compensation paid to patients for medical blunders in Kent's hospitals has doubled in just 12 months. £40 million was paid out in the last financial year for failures such as botched operations. Half of that was for mistakes in the county's maternity departments, with one single case costing £10 million. The NHS Litigation Authority says rising payouts are partly due to the increase in the number of no-win, no-fee lawyers, but it's also calling for better training in labour wards across the country to reduce the risk of mistakes. Dame Joan Higgins is the Chief Executive of the authority.
The single biggest factor, really, was about monitoring the baby's heartbeat. And when we look at the claims made to us, that is the most important issue. So what we're saying to trusts, it's really, really critical to monitor the heartbeat of the baby, and if there's any sign of distress, to respond to it appropriately.
Well, the Royal College of Midwives says it's essential all trusts ensure senior staff are supervising junior colleagues to minimise the risk of mistakes. Pat Gould is the head of the RCN in the South.
I think there are cases where it has been linked to periods where senior staffing is at a lower level than one would expect or indeed wish for.
Let's talk now to Nick Fairweather from Canterbury. He's a clinical negligence lawyer. Good morning.
Good morning.
And Dr. Mark Waterstone, a consultant obstetrician at the Darrant Valley Hospital in Dartford. Good morning.
Good morning.
Dr. Mark Waterstone, let's start with you. I mean, you look at the bare figures and you think 40 million paid out, that's a huge amount, half of that in maternity cases. And before we get into the kind of the rights and the wrongs of how people claim money, I mean, we're talking about lives ruined here, aren't we? Especially when there's that kind of emergency in a birth and a baby is starved of oxygen. It's a lifetime of care we're talking about, isn't it?
It certainly is, and it can take just 10 minutes to ruin a baby's life if it's completely starved of oxygen. So we have to act very quickly on any abnormalities in the fetal heart tracing.
And to try and prevent this kind of thing happening, we heard there from the Royal College of Midwives saying trusts need to make sure there's more senior staff on supervising junior colleagues. I mean, evidently, if we're paying out £20 million in Kent for blunders on maternity wards, that clearly isn't happening, is it?
Well, I think it is happening. Certainly at Darrant Valley, we've gone up from 60 hours of labour ward cover, dedicated labour ward cover consultants, to 92 hours with more consultants. But the errors are made at the very low level, and if, let's say, a midwife is watching a baby's heart tracing and doesn't report abnormalities to the registrar or the consultant, the consultant or the registrar can't then make a mistake or correct the error.
But your claims have gone up, though, haven't they? Between 2010 and 2011 and 2011 and 2012, payouts specifically in obstetrics rose by over £1 million.
Well, I think people are becoming perhaps more savvy and aware that they can claim, but also the errors are being perpetrated more often because of the lack of training or testing, if you like, of the CTG training. Now,
well, we'll move on to that, but I mean, they wouldn't get the money if there wasn't fault, though, would they?
Oh, well, that's for Nick to say, perhaps, but I certainly, if the fault is recognised, then they should be paid out. These kids need constant 24-hour care, and I think that we should be able to provide that.
Nick Fairweather, have you dealt with many of these cases?
Yes, indeed, and I think what comes out consistently with the figures that are produced by the NHSLA, which oversees all NHS hospital-based care, is that the payouts, and we are talking about huge figures being paid out in these cases, but the amount paid out in respect of relatively few claims is huge. So I wouldn't want listeners to think that haphazard maternity units and mistakes are commonplace, but these are avoidable mistakes, and when they happen, of course they cost the taxpayer a huge amount, but obviously the human cost is enormous, and there's nothing more heartbreaking in my work than working with a family who are watching a child grow with profound disabilities which were wholly avoidable had these kind of mistakes not been made.
And are you a no-win, no-fee lawyer yourself?
Well, most of these cases are brought with the benefit of legal aid, and I think the last time I was talking on Radio Kent, we were talking about possible changes in the legal aid system that would take away legal aid in medical claims altogether. That is going ahead in April, but I'm pleased to say that the government has been persuaded to retain legal aid for birth injury cases, and I think that's a very good thing. They're very difficult cases, and they are fought very hard by the NHS and trusts. And one really needs to prove a case very soundly indeed before one secures a payment. But having said that, I think listeners should understand as well, patients and families are not entitled to redress unless they can prove a case, and they need to prove that really unavoidable errors have been made. The law recognises that all clinicians can make a mistake, and if it's a sort of routine mistake, a mistake that any clinician might reasonably make, then that doesn't sound in damages. It has to be a mistake that no reasonably competent person could have made, and that's what we're dealing with here.
Understood. But as far as the removal of legal aid goes for all other clinical errors, bar obstetric ones, that isn't great news. A lot of people saying this is not great news for the patients.
Well, it's not, but I mean, I think it's a whole other topic really, the availability of litigation funding, and I think although they're very contentious, I think no-win no-fee agreements have in reality opened up access to justice to middle-income England, as it were, in the way that sort of 15 years ago it was only the very rich or the very poor who could litigate. But what I would say with legal bills and with NHSLA bills, these cases with these avoidable mistakes, it's overwhelmingly the obstetric cases that cost the NHS a huge amount of money, and so everyone's got a common interest here, it seems to me. Clinicians, patients, everyone involved in the process has a common interest in learning from the mistakes that have been made, and it's been a very interesting NHSLA report that was produced a short while ago looking at over 10 years of their data and their experience and really pinpointing very clearly the sort of errors that give rise to these claims, and they are avoidable errors, and it is about training, it's about CTG traces in particular, it's about collegiate working within maternity departments, and it is about resources. And of course we've seen in some local trusts moving services, for example, from Maidstone to Pembury, and leaving Maidstone with midwife-led rather than consultant-led services. These are all issues that really need grappling with, and I think one of the problems is that politicians and people in charge of health service budgets really have a sort of short-termism to how they're looking at things, and if they can save a bit of money today, they don't necessarily look at the long-term possible consequences.
It's the same the world over, isn't it, at the moment? Mark Waterstone, now you mentioned earlier you think there should be regular testing of because obviously nurses get the training in how to monitor the heartbeats of an unborn baby, but you're saying they need to be regularly tested, because what have you witnessed? What have you noticed that is not happening?
Well, the CNST, which is the Clinical Negligence Scheme for Trusts, which indemnifies the trust, insists that you have regular updates of CTG training, but that does not stipulate that you then have to be tested to ensure that you have retained the knowledge. All it says you have to attend, sit in the seat, and then go away again. My analogy is would you fly in a plane where the pilot's learnt it but hasn't been tested? Or if you're doing a driving test, you do the theory but not the practical. What I've noticed is that I do a CTG masterclass on a regular basis, and people are very afraid of being tested because they've been tested when they did their midwifery or finals or even their medical finals, but they don't like being tested again and again and to be exposed as perhaps failing. A second issue about that is what do you do with those who don't pass, because that does have an issue for the employment. But in my experience, I did this when I was at Queen Mary's. I trained and tested every single member of staff, and very, very few failed the test on the second time. And the improvement in understanding and interpretation of CTG monitoring was quite dramatic.
And when it's such a crucial matter, but the difference between life and death or a lifetime of disability,
absolutely, it
seems like a very sensible step forward. Thank you so much for joining us this morning. Dr. Mark Waterstone there, consultant obstetrician at the Darent Valley Hospital in Dartford, and also Nick Fairweather from Canterbury. He's a clinical negligence lawyer, talking about the rise in compensation payouts in Kent for medical blunders has doubled in the last 12 months.